Hello and welcome. This is ESICON 2018 and this is day 3. We are live on ESI TV, an academic initiative by Torrent Pharma in association with Medwiz Healthcare. Well, we have been talking about the scientific program across the 4-day span here at ESICON 2018 from the experts themselves, and in conversation we have Dr. David Torpy all the way from Australia. He's the Deputy Director, Endocrine and Metabolic Unit, Royal Adelaide Hospital. Hello sir, welcome on board with us. And alongside we have Dr. Vipin Talwar. He is the Director and Consultant Endocrinologist at Golden Hospital, Jalandhar. Well, so let's talk about the entire vibe here at the City of Temples, Temple City of India, Bhubaneswar 2018. How does it feel to be a part of ESICON 2018? What are the academic initiatives? What kind of vibes are? So we'll begin from you.
Well, it's been an honour to be invited to India and the very interesting city of Bhubaneswar. The meeting has been very diverse. There's been a lot of huge areas of endocrinology covered by many experts, both from within India and elsewhere. And for me, it's been particularly interesting to hear about the special challenges of endocrinology in India.
Sure. Dr. Talwar, would you like to add something about from your experience here?
Yeah, it's a great meeting actually. This ESICON has been one of the marvelous one which I have attended in the last many years. I am a regular visitor to ESICON, but this time meeting was just simply great.
Yeah.
Maximum number of attendees, and even the sessions, they are much more elaborate than what we had in the last few years.
Absolutely, and we have pan-India faculty members who've joined in alongside international speakers who've joined on board with us this year, every year, which is the case, but I think the number is just expanding every passing year. And ESICON 2018 has also witnessed many interesting interactive initiatives. For example, the EPL, so the Endocrine Premier League, a grand debate contest that was organized. The East Division came out to be winners, turned out to be winners, alongside the Panchayats. So were you here yesterday? Yeah, so there was, so what happens here in the rural area, we have Panchayats. So there's this one stakeholder, this one main important authorized person who's called the Sarpanch. So he's the head of all the public, and then they have 5, what do you call? Panch. So Panch. Panch is 5 in Hindi. So there are 5 people under him, and then whatever socio-economic issues that they face in the community or in that region, these guys bring to the Panch, and the Panch and the Sarpanch, the head, they do a panchayat, like a gathering, a meeting with all of them present, and they talk out on certain issues. And that is what the idea was from yesterday's panchayat, that endocrinology topics were discussed in such an interesting way. Yeah, so many other interesting things. Tonight we're performing Colors of India, where it's a cultural extravaganza. I would let you know that flavors from the world, folk dances of India is something that you would want to attend, not miss. So tonight is Colors of India. All right, now let's get talking about the sessions or the symposium that you guys have spoken for. Sir, I understand adrenal insufficiency in children has been your topic. Would you like to give us a quick comprehensive insight over the same?
Okay, so I covered adrenal insufficiency quite broadly with some focus on children. But apart from a general session, I tried to address some of the particular challenges in adrenal insufficiency that are still left despite pretty standard and accepted therapy. Now, those challenges include delayed diagnosis, which is very common, and this leads to many patients living for long periods of time with very impaired quality of life and well-being before they get treated. And the evidence is that if you don't get diagnosed early, even after treatment, if you survive that period of non-diagnosis, well-being is impaired. So we discussed that issue. It's not an easy problem to fix because many of the symptoms of adrenal insufficiency are really quite diffuse and not especially specific. A second problem is the problem of glucocorticoid dosing and selecting the correct dose. remembering that individual people vary about threefold in the amount of cortisol that they make. We don't know when they're diagnosed with adrenal insufficiency how much they need. So it is a challenge to find the correct dose for the individual. That's actually easier in children because you have growth velocity to study and you can sometimes adjust dose on that basis. But in adults, it is quite difficult to discern exactly what dose is required. Adrenal crises are still a problem, and they're actually increasing in frequency, and we discussed that. And finally, despite apparently best practice treatment, there is still a proportion of people, perhaps 40%, who report some impairment of well-being. And we discussed the reasons for that and what further work might be needed to elucidate the causes in individuals and better deal with that problem.
Sure,
Dr.
so
David,
yeah.
sorry
Would you like to add
interrupt.
something?
Yes. I would like to have a couple of more informations, Dr. David. So out of the various glucocorticoid replacements which we use, hydrocortisone, prednisolone, even dexamethasone, which one you prefer in your practice?
Well, I think the preference has been quite generally to use hydrocortisone. Now, or cortisone acetate. Both of these are short-acting glucocorticoids. The drawback is, and of course, they mimic natural cortisol, which is in fact hydrocortisone. Now, these natural short-acting glucocorticoids are theoretically attractive, and in the last 20 years, most people have switched to those as the primary treatment. The downside, however, is that they require more frequent dosing because of their serum half-life is generally about 90 minutes. And so that is a burden. People are being asked to take glucocorticoids generally 3 times, at least twice, or sometimes even 4 times a day, in an attempt to mimic the circadian rhythm. I think we've walked into that problem without necessarily considering all of the downsides, and surveys of patients have shown that this is a considerable burden, taking frequent dosing of tablets. So I think we cannot make a blanket statement that this is perfect for everybody, and the use of longer acting steroids such as prednisolone, which has a serum half-life of 150 minutes, is more suitable. I don't think dexamethasone is preferable in most patients. There are some patients where it may be a better choice. It is very long acting, however, it has no mineralocorticoid effect. It crosses the placenta, so in pregnancy it's not ideal. And the preparations of tablets are such that dose adjustment is in a precise range is quite difficult.
So the dictum is that hydrocortisone or the cortisone remains the drug of choice. So my dear, once I have chosen hydrocortisone as my drug, now you said 2 doses or 3 doses.
Yes.
So where 2 doses, where 3 doses?
Yeah. So the studies of that have mostly looked at well-being, and people generally experience better well-being with more frequent dosing, such as 3 times a day. Some patients, however, cannot remember the middle dose because they're busy during the day, and twice a day is an option, with the second dose being given in the afternoon after lunchtime, perhaps around 2 p.m, with about 2/3 in the morning and 1/3 in the evening. 3 times a day might produce a little more of a circadian cortisol response, but it has the drawbacks I've already mentioned. I think there are options. At the moment, there are newer preparations which such as Plenodrin, which is once a day, or Chronocort, which is twice a day. These medications are quite expensive. They're delayed release hydrocortisone. They may have a theoretical benefit in producing a more circadian cortisol pattern. The problem is that they really have not been submitted to a double-blinded controlled study. So I think that third-party payers are unlikely to fund these for good reason, in my opinion, and we need these types of studies. The hypothesis that a closer to normal circadian rhythm is preferable remains, in my opinion, a hypothesis. We did a pump study using an insulin pump of hydrocortisone to mimic the circadian rhythm and didn't show any improvement in well-being. That's the only study that's ever been done in a randomised, controlled, double-blind fashion. So I think at the moment there are some unanswered questions on the ideal best way to provide glucocorticoids in Addison's.
And what is now the usual dose of hydrocortisone? Is it 20 milligram, 15 or 12.5 or even 10?
The preferred dose range for adults is 15 to 25 milligrams per day and approximately 8 to 12 milligrams per square metre body surface area in total daily dose in children.
Yeah, that's
I think that was very insightful and very, we've got into the seriousness and concerns of the topic, but what I've realized is the right amount of screening, therapeutic or diagnosis, the drug monitoring plays a major role in there. And doctor, talking about now whatever he's spoken about, the topic is far vast and very different than to yours. Hypogonadism has been the talk session for you. So Dr. Talwar, would you like to convey our audience and sir here that what exactly, what were the recent developments and newer advances and clinical developments for this topic?
So hypogonadism, the main concern which I was speaking was regarding the Turner syndrome. So Turner syndrome, as you know very well, it is a chromosomal anomaly in which the girl presents with 45XO. Normally she is supposed to have 46XX. That one chromosome, it goes away, that X chromosome, and she comes with 45XO. And problem is, these girls, they will come with a short stature, some structural abnormalities like webbing of the neck, some change in the angle of the hand, may have some problem with intelligence. So these are the somatic things which we are able to see. On the other hand, there are some other issues which the one of which is usually overlooked is the CVS abnormalities, especially the coarctation of aorta. So that's why it is said, once you see a child or girl with the Turner syndrome, you should see the blood pressure, check the blood pressure in all the 4 limbs, because these children, they may have normal BP in the upper limbs, but the lower limbs may have very low BP because of coarctation. Similarly, chances of hypertension as such, they are high in these girls. And the more concern is coming that what should be the management. We have to start with them for the short stature as a growth hormone. So how early has to be started? Now there are studies coming up that it can be started as early as 2 years of life.
Correct.
Earlier on we used to delay it, maybe to say 4, 5, 6 years. Now the data is coming that even growth hormone can be started by 2 years of age. And even one study is coming up, which Professor must be aware, they have started the growth hormone in the toddler itself. So by age of 9 months, they have started growth hormone, followed them up for 2 years, and they have found that their height became normal to or equal to those children of similar age with the 2 years therapy with growth hormone started at age of 9 months. So growth hormone therapy should be started early. Second issue is how long to give it, because it is a costly therapy, especially in our country. In our country, Professor David, most of the medicine they are bought by the patient themselves. The government is not sponsoring much of them, and we don't have much of insurance cover. So most of growth hormone, which is very expensive, is bought by the patients or the family. So the question is how long we should give it. So the consensus is now coming up, we should give it till the bone age becomes 13 to 14, or your chronological age is up to 14 years. And simple clinical parameter remains once your growth rate velocity. That means 1 year growth is up to 1 centimeter or less. So till that time you can continue with the growth hormone. And a third thing which is important in these patients is induction of puberty, because they don't produce sex hormones of their own. So these hormones, they are to be supplemented. So they are usually supplemented by age of 9 to 10 years. In your countries, you usually use oxandrolone as a you can supplement as a supplement to the growth hormone. But in our country, we don't have oxandrolone. So we have to start with directly with the estrogen therapy. So we usually start with the estrogen by age of 11 to 12 years. And it is said that at least 4 years of growth hormone therapy must be given before we start the estrogens. And we start estrogen in a very low dose. Estradiol is our preparation which we use, and we gradually escalate the dose so that in a period of 3 to 4 years, we are able to achieve the normal puberty in these girls.
Sure. So would you like to?
Sounds as though you're diagnosing and treating very young children. Do you find we've over the years heard of associations with genotype to phenotype, such as the ring chromosome and neurocognitive development. do you find practically, clinically, as a paediatrician, that genotype-phenotype correlation is of value to you prognostically or in therapy?
Yes, there has been some changes, especially those girls who have got not a pure 45XO, they have got some mosaicism. So that is one area which is very interesting as far as this phenotype-genotype correlation is concerned. And this group is also very important because if we have the X, along with X we have the Y cell line, then that management of that gonad is also very important. So because that Y line which is present, it is a predisposition for a future malignancy. And the chance of getting malignancy in these patients may go up to even high up to 30 to 40%. So as soon as if we are able to find any Y line in the patients who are having 45XO, XY something, we are supposed to treat it surgically. Another question comes, how do you treat it? Which surgery you will do? Whether you will do the laparoscopically or you want to do open laparotomy. So that's another question, and that depends upon the tumor markers. So if your tumor markers are low, possibly you can go ahead with your simple laparoscopy, and if they're high, then preferably you should go with the laparotomy, open laparotomy.
What advice do you have about the giving of sex steroids in a girl who's perhaps anxious for sexual development, but you feel that there's some growth potential left with the growth hormone? Do you find that sometimes a difficult balance, or how do you advise patients in that area?
So in these patients, first of all, here the thing comes as counseling. So you have to sit with the child, with the parents, and discuss all these issues together. So let it be a decision between the family, doctor and the patient herself. So what exactly she wants and what are the potential benefits of her getting stature. So there was a old school of thought in which we used to give very low dose of these eastern estradiol. They used to call micro doses, and they were started by the 9 to 10 years. And they said they used to not only potentiate the sense of well-being in these patients, but they also help in getting some stature. But the recent guidelines which have come up in 2016, the Cincinnati guidelines, they are saying that possibly the use of this low dose micro eastern estradiol is not that use. So basically it will be the decision between the patient, doctor and the family regarding when to start the sex steroid therapy.
What do you think are the main issues in transition of children to adult physicians? What do you think in that transition phase is important?
So something is, one is more concern that as the child grows up, she, with her peers, the other people, she sees why I am needing medicine for all those things for which my other friends are not requiring anything. So this is one thing. Second is the concern that I will be dependent upon the medicine for menstruation. So this is second concern. And third thing is regarding the stature itself. In spite of all growth hormone or any sex steroid therapy, we are able to boost up the height by only 5 to 8 centimeters. So by that she may not be reaching that height which the girls these days they expect for themselves, but still it is better than what we used to have, say, about a couple of decades ago.
So that's been the talk. Doctor, once when we're talking about this topic, I would also like to mention that the socio-economic issues that we face here in our nation are a serious concern when it comes to topics like these. And what kind of efforts, Dr. Talwar, as a nation, as society, do we need, as the doctors fraternity, do we need to take into such topics?
Yeah, definitely, because any expensive therapy, see, all patients, they are unable to afford the treatments. So we have got some NGOs, some NGO groups which are working with us. So whenever we get some patient of this type, then we usually approach those NGOs, and they usually help these patients completely or sometimes partially. So this is one part. Second thing can come from some of the government agencies. There are some schemes that are going on which reimburse some of the treatments. And thirdly, luckily now some insurance companies, they are also now covering the expenses of such a costly therapy. So it is all at the level of the, you can say, NGOs, government, as well as the insurance companies. And as a person, what we used to do with our patients is, what we can do is we can give subsidy regarding the investigations, regarding the consultation charges, and that is the best we can do, and which we are already doing.
Sure, I think the conversation has been really insightful, and a lot of take-home pointers the audience must have already fetched. Thank you so much, Dr. Talwar, and thank you, Dr. Torpy, for joining in with us. It's a pleasure having you here on ESI TV. Thank you.